Hi, good morning, and welcome to the second session of our webinar on WHO clinical perspectives on COVID-19. We are going to discuss today the topic of sepsis and septic shock. And we now have 116 attendees on Zoom, and on YouTube, we are looking at 49. We expect the numbers to go up as we move along. So again, I'd like to welcome everyone to this session. My name is Dr. Albert Domingo from the WHO Country Office in the Philippines. Joining me are Doctors Gary Kuniyoshi, James Heffelfinger, and Sophie Dennis, all from the Regional Office for the Western Pacific. And in that regard, without further ado, let's turn it over to Gary. Over to you, Gary. Gary, just a few technical difficulties.
Yes, I'm screen here.
Right. I can share your slides for you if you'd like.
Are you able to see my screen?
Nope. Try clicking on share screen at the bottom. Apologies to our participants. We're following work from home guidelines. Here we go. Sharing now. All right. And can you click on slideshow, please, Gary? All right. Over to you.
Good morning. Today's topic is sepsis and septic shock. The learning objectives today are the recognition of a patient with sepsis or septic shock. We'll be focusing on delivering targeted resuscitation, primarily in adults with septic shock. The principles of sepsis management are these three. The first principle is recognition of patients with sepsis and septic shock. The second is appropriate antimicrobials within 1 hour of recognition. And the third is targeted resuscitation. So how common is sepsis and how common is shock in COVID-19? It's hard to define. The reporting demonstrates very high variability. Studies range from as low as 1% to up to 35%. This, of course, dependent on the patient population, especially age and amount of comorbid factors, such as cardiac disease. Also depends on how ill the patients were in the series. Most importantly, though, it's their definition of shock that they use, which we will talk about in more detail. The data we have from China, in one study, over 2,000 patients, about 5%, were critically ill with shock. In another study by Guan et al., over 1,000 patients, only about 1% developed shock. So this is a good tool to use at the bedside to diagnose sepsis or septic shock. It's called the Quick SOFA or QSOFA score. SOFA stands for Sequential Organ Failure Assessment Score. You look at blood pressure, mental status, and respiratory rate. Specifically in patients with suspected infection, the presence of 2 or more of these QSOFA points are associated with an increased risk of death. So let's go back. What is the definition of sepsis and septic shock? We use what's called the consensus definition for both of these. The consensus definition of sepsis is a life-threatening acute organ dysfunction secondary to a dysregulated host response to infection. So sepsis is acute organ dysfunction. Septic shock is defined as a subset of sepsis in which underlying circulatory, cellular, and metabolic abnormalities are associated with a greater risk of mortality than sepsis alone. So septic shock is a subset of sepsis with higher mortality. So the current definition of sepsis has these three components. You have number one, suspected or documented infection. Second, an acute life-threatening organ dysfunction, and this is caused by number three, a dysregulated host response. Septic shock is a subset of sepsis with a higher death. Sepsis and septic shock are a spectrum of disease. With sepsis on one end, the mortality rate is around 10%. The other end of the spectrum is septic shock with a mortality of about 40%. We use a more functional or clinical definition of septic shock, and it has these two components: persisting hypotension despite volume resuscitation and requiring vasopressors to maintain adequate blood pressure. And number two, a serum lactate level of greater than 2. So sepsis and septic shock is acute life-threatening organ dysfunctions. How do we recognize these acute organ dysfunctions? Well, mainly through our physical exam and laboratory testing. Exam of systems such as the nervous system. You can use any kind of standard scale, such as AVPU, alert versus other. You can also use what's called a RAS score, which is a score for agitation and sedation, or the CAM-ICU, which is a delirium scale. Looking at the kidneys, following urine output hour by hour. The skin exam also includes looking at the capillary refill and the strength and quality of the pulses. And then laboratory testing can be markers of single organ perfusion, such as creatinine, or can be a global marker of perfusion, such as lactate. Putting these together, you can use what is called the SOFA score, the Sequential Organ Failure Assessment Score, and it looks at 6 different systems. First, you're looking at the central nervous system. You do a calculation of the Glasgow Coma score. Looking at the heart, you look at the mean arterial pressure and amount of vasopressors that you need. Looking at the lungs, you do what's called the P to F ratio. So you will need an ABG to calculate this. For the kidneys, you have to look at the creatinine or urine output. So you may need a renal panel. For the blood, you look at the platelet count. So you need a CDC. And for the GI system, you're looking at the liver. And so you're doing a calculation of the total bilirubin. So you need a liver function panel. The higher the score, the more organ failures that you have. So this takes us back to, again, at the bedside, a good screening tool. And this one only requires you to look at 3 organs instead of 6, and no laboratory test needed, is the Q-SOFA, or the quick SOFA score. Why is the Q-SOFA so useful? If you take all the patients that have infection and you use the Q-SOFA criteria, you can identify the vast majority of those that are increased risk of death. So using Q-SOFA score in patients that have suspected infection, you can identify the patients that you want to. So going back to our principles of sepsis management, the first step is recognition of sepsis and septic shock. The second is appropriate antimicrobials within 1 hour. We will be covering antimicrobials in more detail with tomorrow's lecture, but I'll just highlight a few points here. Prompt administration of antimicrobials within 1 hour has been shown to reduce mortality in septic shock. Remember, the infection is what caused acute organ dysfunction and the dysregulated host response. Thus, administration of antimicrobials would be a high priority. The standard is 1 hour within 1 hour recognition of sepsis or septic shock. And specifically in septic shock, each hour of delay to give appropriate antimicrobials, the mortality increases by 6%. These includes antibiotics, but also antivirals. And this will be described in the next presentation tomorrow. So the third principle is targeted resuscitation. So these are the targets of resuscitation. Based on evidence from clinical trials, the following targets are recommended. First, improved blood pressure. We use a mean arterial pressure, which is a true driving pressure perfusion. Second, adequate urine output, and this is measured per hour. Third is skin exam, which does include capillary refill and peripheral pulses. And then improved sensorium using whatever standardized scale used, and then normalizing lactate. So the way I think about it is these 5 together, and I think of this word HASL. It's not really a word, but this is how I remember the 5. First is hypotension. You want to reverse it. And you're aiming for a mean arterial pressure of greater than 65. We use a mean arterial pressure because it is derived from both the systolic and the diastolic pressure, which is the true driving pressure. An alternative is using the systolic blood pressure of greater than 100. Also, next, you're looking for altered mental status improvement. So you want patient is alert or Glasgow Coma score of 15 or a RASS score of 0. Next, you're looking at the skin, which does include the pulses. You want warm, dry, and no mottling. In addition, you want pulses that are strong. Urine output, you're looking for greater or equal to 0.5 milliliters per kilogram per hour. So for the average size adult, this comes out to about 30 cc's an hour. And then last, you're looking for lactate clearance or normalization if the initial one was elevated. So these are our 5 resuscitation targets based off of clinical trials. Related to the targets is something called fluid responsiveness. So in sepsis physiology, there are several mechanisms that cause shock. One is hypovolemia. When you give fluid, the stroke volume, which is the amount of blood pumped out with each heartbeat, increases. And this increases cardiac output and improves perfusion. On the left there, you see the famous Starling curve. This is the preload or fluid filling on the x-axis versus cardiac output on the y-axis. So you see this response to fluid that you give in cardiac output. So for example, going from 0.1 to 0.2 on the curve, for a given amount of fluid, you see a very big rise in cardiac output. Then when you go from 0.2 to 0.3, for a given amount of fluid, you do see a rise, but it's less of cardiac output. By the time you get to 0.4 to 5 on the curve, for a given amount of fluid, there's almost no rise in cardiac output. So we would like to know how to predict where we are on this curve. Is the patient going to be fluid responsive? Does the patient need more fluid? So these are 3 tools that can be used to predict fluid responsiveness. And they include what's known as passive leg raise, which is a static parameter. Number 2 is cardiac ultrasound. So looking either at ventricular function or the inferior vena cava size. And this is a dynamic parameter. And then third, looking at central venous pressure monitoring or CVP monitoring. This is also a dynamic parameter, but it's an invasive procedure that needs to be done. With a passive leg raise, what you're doing is you're mimicking a fluid bolus of 300 milliliters. When you raise the legs 45 degrees, the blood from the legs goes into the heart. However, to get an accurate prediction of the fluid responsiveness with the passive leg raise, blood pressure reading is not enough. You must use some kind of cardiac output measurement with either cardiac ultrasound or use of an arterial line, which is another invasive procedure. With cardiac ultrasound, you're either looking at the ventricular outflow or a change in the inferior vena cava. There are many caveats to correct interpretation of these findings. And in general, it requires skill and expertise. The last predictor of fluid responsiveness is central venous pressure, or CVP, which requires placement of a central line. The pressure is measured wherever the tip of the central line is at, usually at the junction of the superior vena cava and the right atrium. You can infer what the pressure is in the right atrium by detecting the pressure at the tip of the catheter. The CVP, or the central venous pressure, can be used as a static measure, which means you just measure it several times a day. For example, if you get a CVP of less than 8, that may indicate that the patient's fluid responsive. You can also use it dynamically, which is continuously monitoring the central venous pressure, and you're watching the changes in central venous pressure along with blood pressure and cardiac output after giving fluid. So for example, if the blood pressure and cardiac output do not rise and the CVP does not rise also, when you're giving fluid, then the patient may be fluid responsive. An important point is that these predictors of fluid responsiveness, especially the invasive ones like central venous pressure, they are not superior to the 5 clinical targets of resuscitation: the reversal of hypotension, altered mental status, skin signs, urine output, and lactate clearance. However, these predictors of fluid responsiveness can be used as adjuncts to help guide patient care, as long as their meaning and limitations are fully understood. So once again, these are the 5 best surrogates for adequate perfusion. These are the 5 targets based off of clinical trials, and they include hypotension reversal, altered mental status improvement, skin examination that's normalized, urine output that's adequate, which is greater or equal to 0.5 milliliters per kilogram per hour, and lactate levels that normalize if the initial one was elevated. So how is resuscitation of septic shock specifically done? So first given are crystalloids. So in adults, the recommendation is give 250 to 500 milliliters in the first 15 to 30 minutes or faster. In children, the recommendation is 10 to 20 milliliters per kilogram in the first 30 to 60 minutes or faster. Along with each of these, you're doing sequential evaluations to assess the clinical response. Next is vasopressors, and this is to maintain an initial MAP goal of 65 millimeters of mercury. And the first line agent is norepinephrine. So this is the first and second line resuscitation for septic shock. Other things are adjuncts, such as adding inotropes or packed red cells. And we'll talk about a few other medications also. So crystalloids are the preferred fluid. So it is recommended to use a balanced solution. By balanced solution, for example, lactated ringer solution is a balanced solution, which means it's pH balanced. Normal saline is normal osmotically. That's where we get the word normal from, but it has a low pH and can cause a non-GAP hyperchloremic metabolic acidosis. It is specifically recommended not to use hypotonic fluid, such as dextrose in water or even half normal saline. Certain colloids, such as starches and dextrans, are also advised against. They are associated with renal problems, acute kidney injury, and requiring renal replacement therapy and even higher mortality when you administer these products. So when to stop giving fluids? So first, once you reach the targets of resuscitation, if you met your targets, then you can stop giving fluids. Second, if there's signs of fluid overload, or if the patient's no longer fluid responsive. So while you're treating for sepsis and septic shock, you should be closely monitoring your patients for signs of fluid overload, such as pulmonary edema, crackles on auscultation, or findings on chest X-ray. Or if you have a CVP that you're measuring, if you have a very high CVP, which it's generally greater than 8 to 12. The risks of excessive fluid are the following. So excessive fluid is very detrimental. It can cause increased tissue edema, worsen hypoxemia, worsen cardiac function. It increases length of stay, morbidity, and may increase mortality. If your mean arterial pressure remains less than 65, despite adequate fluid resuscitation, then next you start a vasopressor agent. So the mean arterial pressure target, according to the guidance, is 65 millimeters of mercury in adults. Okay. However, you should individualize based on the patient's history. For example, patient has a history of hypertension, you may target a higher MAP, such as 70 or even 80. You need to consider other markers of perfusion also. So the other ones are looking at your mental status, your skin, your lactate and urine output. For example, if you had all of those and they were all normal, then you may elect to target a lower MAP, such as 60 or even 55. So vasopressors. First choice of vasopressor agent is norepinephrine. The reason is there's more vasoconstrictor effect and less what's called chronotropic effects. So there's less tachyarrhythmia caused than when you compare with medication like dopamine. So norepinephrine is first choice. Second choice, according to the guidance, is epinephrine. You could also use fixed dosed vasopressin if it's available. With epinephrine, you can also get the chronotropic effect that is seen with dopamine. But specifically, dopamine should be avoided due to risk of tachyarrhythmia, especially in the context of COVID-19 infection. In older persons, dopamine should be avoided. So delivering vasopressors through peripheral IVs, there is a risk, and the risk is extravasation of drug into the soft tissue, causing skin necrosis. So the recommendations is when you're using vasopressors, central venous access if possible. Otherwise, very close nursing care to check the infusion site frequently. If extravasation does occur, you could consider using a vasodilator, a topical vasodilator like phentolamine. So adjunctive measures that you consider adding are inotropes. This should be based on assessment of the cardiac function, usually via echocardiogram. And dobutamine is a very strong inotrope and also a mild vasodilator. This is the first choice of inotrope. There is a risk of tachyarrhythmia very similar to dopamine, and it can cause hypotension because dobutamine is a weak vasodilator. Blood, packed red cells should be given if there is severe anemia, which means a hemoglobin of less than 7 grams per deciliter. Giving blood to raise hemoglobin any higher than 7 grams per deciliter is not associated with better outcomes. And there are adverse effects with blood transfusions, such as increased infections, lung injury, and transfusion reactions. There are a few caveats, a few exceptions to the 7 grams per deciliter target. In cases such as severe hypoxemia, myocardial ischemia, or active bleeding, you could consider keeping a higher hemoglobin than 7 grams per deciliter. So for resuscitation for shock, use targeted resuscitation. First line is fluids. These are boluses followed by sequential evaluations to assess clinical response. And second is vasopressors to target a mean arterial pressure of 65. And first line is norepinephrine. The other medications are adjuncts to use in other situations. So a few other drugs that we'll talk about are corticosteroids. There have been many studies evaluating the use of corticosteroids in sepsis and septic shock. So if shock is refractory to targeted resuscitation, which means you're giving fluid and you're also requiring escalating doses of vasopressors, then you could consider adding IV low-dose hydrocortisone. The main risks of low-dose steroids are hyperglycemia and hypernatremia. And the other risks that we often worry about, such as weakness or increased infection or GI bleeding, recent reviews have found no clear association when you use low-dose steroids with these other risks. The recommendation is do not use more than 300 milligrams a day of equivalent hydrocortisone. So the dosing is from 200 to 300 milligrams per day. You only use in sepsis with shock. So do not use in sepsis without shock. Also, do not use to treat viral pneumonitis or influenza pneumonitis. But you can use for other indications, other kind of respiratory indications, such as asthma or COPD, or even there's some use in late stage ARDS. So another treatment studied in critically ill patients is insulin therapy. The current recommendation is to avoid tight control. By tight control, it is from 80 to 110 milligrams per deciliter. You only initiate insulin therapy if the glucose rises on several measurements above 180. Again, avoid intensive insulin or tight control because it increases mortality in critically ill patients. Remember, to deliver any kind of insulin treatment safely requires frequent glucose monitoring to avoid the harmful effects of severe hypoglycemia. So for the WHO guidance, the Surviving Sepsis campaign was referenced throughout. And Surviving Sepsis guidelines made an update that did include COVID-19 recommendations. And their site is survivingsepsis.org. Okay, so the key points, summary. Early recognition of sepsis with target resuscitation combined with early appropriate antimicrobial saves lives in patients with sepsis and septic shock. The targets of resuscitation should be hypotension, altered mental status, skin signs, urine output, and lactate. And for resuscitation for septic shock, fluids are first, vasopressors next, and then next you can add some adjunctive agents. Thank you.
Thank you, Gary. So that concludes the lecture portion. Again, we are now joined by 161 attendees on Zoom and another, let me just check, 147 participants over on YouTube. To our participants, you are most welcome to ask questions using the Q&A function in Zoom and also the live chat function in YouTube. We will be monitoring both channels. If you are in the Zoom chat, if you see any question that you'd like to ask also that someone else has already asked for you, you can click on the like or the thumbs up sign and it will be upvoted, and on my monitor as moderator, it will go up on the list. While waiting for some more questions to come in, I just wanted to note that the targets for resuscitation, you mentioned HASUL, the mnemonic. There's actually a Filipino word, ASUL, A-S-U-L, which is Filipino for blue. So it does resonate as a mnemonic for us, at least in Tagalog, HASUL. Now it's stuck into my head, and probably the participants. Hypotension reversed, altered mental state, skin exam, urine output, and lactate. Color blue, which is what we want to avoid when it comes to critical patients. And we have a few questions now. So here we go. From Samuel Ong, given that invasive hemodynamic monitoring is generally not superior to clinical assessment in resuscitation, is there a particular subset of patients for which invasive monitoring, like measurement of PCWP via a Swan-Ganz catheter, is warranted? Gary?
So I can speak to the guidance. So the guidance says that using dynamic parameters are generally recommended over static parameters. So if you're using them as dynamic parameters and you have experience with it, and you have patients that are needing higher and higher amounts of vasopressors, for example, then the guidance would support use of some of those invasive monitoring. If you had experience using them, you knew how to interpret it.
All right, from the chat box.
Can I say one thing that may not be WHO guidance, but I think, and Gary, you may be able to answer this, but if you have access to such modalities, and you know, in certain times there are questions about, is this septic shock, or is this cardiogenic, or is it something else? I mean, in some settings that you will get benefit from them, but there's some settings where either you don't have, you know, for a variety of reasons, either the reason for the septic picture is clear, or you don't have those modalities present. Over.
Follow-up question. I'm looking at the chat box. So Obet Chan is asking, I'm assuming this is a jugular venous pressure, JVP. What about monitoring JVP in places where the suggested monitoring interventions are not available?
So that's a good question. So what we're talking about with CVP is putting in, or central venous pressure, is when you put an invasive catheter into the internal jugular vein, and then you're measuring the pressure at the tip of that. And it's usually in the superior vena cava, but it can be in the first part of the right atrium. JVP is doing a clinical exam and looking at the neck veins. That's not what we had specifically talked about. You can use that in addition to your other clinical findings, but specifically what we talked about today was predicting fluid responsiveness is using a central venous pressure. And of course, using central venous pressure monitoring, it would require you to do an invasive procedure. There are some complications that can be with that. Of course, if you did a physical exam and you're very good at it, then that doesn't have any complications that go along like you would with putting in a central line.
All right. Here's another question related to pressures. Considering, so David Bildan is asking over YouTube, considering the target mean arterial pressure in general is 65 millimeters mercury, how do we adjust the target MAP for patients with underlying hypertension suffering from septic shock? For example, if their usual blood pressure is 140/90, so how do we adjust?
So that's a very good question. So that's why the targets, there are 5 targets, and you need to be evaluating all of them. So the general recommendation is to use a MAP goal initially of 65. But if you're finding that you're not able to get to 65, for example, you had a patient with underlying hypertension, say all your other parameters were normal. Your mental status was good, urine output was very brisk, the lactate was clearing, the skin signs showed no modeling, then you could aim for a lower mean arterial, a higher mean arterial pressure because you met those goals and the patient's normal pressure may be higher. Okay, so if you're suspecting that the patient's normal pressure is higher, then you could aim for a higher MAP than the 65. And if you find the same types of things and the patient doesn't have history of hypertension, you could actually aim for lower. You can aim for 60 or even 55 because the other markers are showing adequate perfusion.
Any additions, Sophie or James? All right. So next up, thank you for your informative lecture. May I ask, at what dose do you recommend for norepinephrine during the initial resuscitation?
Okay, so inside the toolkit, there is a medication dosing. It doesn't give specific dosing. It says in there you could start at 0.1 micrograms per kilogram per minute. That may not mean anything to you, but it doesn't give a maximum either. But it says once you reach 1 milligram per kilogram per minute, then you are at refractory levels. So if you're using upwards of 60 mics per minute, that's refractory. But you generally start low and then you slowly titrate up to reach your MAP goal of 65 millimeters of mercury.
All right, from another anonymous attendee, still related to pressures, are there some patients with COVID-19 that develop third spacing of fluids, particularly in the lungs? This would clinically present as a low blood pressure, but with signs of fluid overload or respiratory difficulty. In this case, would it be prudent to continue fluid resuscitation and intubate the patient to support ventilation?
That's a very good question. So let me see if I have this question correct. You're having evidence, you're doing fluid resuscitation, you do have evidence of pulmonary edema, but you're not sure if the patient has enough volume in their vasculature, or maybe their lungs are just getting worse and they're developing what we know as ARDS.
That's right.
Yes. So that is a very good question. That is very difficult. You would use your 5 parameters and try to target those 5 parameters and using those other measurements to see if the patient is fluid responsive. The non-invasive ones probably are best to start out with. So using things like cardiac ultrasound, looking at the IVC, looking at the cardiac output. Using the passive leg raise, you would need some kind of continuous cardiac output monitoring to see the changes. But using something non-invasive first would probably be the thing that's recommended. And then going on to other invasive things such as CVP measurements. And then you had mentioned before using things like what we call a Swan-Ganz or a pulmonary artery catheter.
All right, so just a quick check, 154 attendees on Zoom, 145 on YouTube. I'd like to assure everyone that I'm seeing all of the questions, and it's just that if it's related to the previous question, I'm giving it a bit of priority. So here's another question from Hazel Dokuyanan. Based on references, norepinephrine should be administered via a central line. In the slides earlier, it was mentioned that it can be given by peripheral line and just give phentolamine when there is necrosis. Does the guidance support giving norep via a peripheral line? Is there an alternative for phentolamine since it is not available in the Philippines?
So the guidance is written for low and middle income countries, and it realizes that some of these locations, they do not have that capability to place central lines. And if they could place central lines, they may not be able to do it with the appropriate measures. So administering vasopressors through peripheral IV does have known adverse effects, including these tissue necrosis. So it is recommended that if you do have that capability to put in a central line when you're using vasopressor agents, but if you cannot, you still need to administer the vasopressor agents to do the resuscitation. Regarding the phentolamine, that is a medication that's recommended there. There's no other specific guidance on that. What phentolamine is a vasodilator. So there's going to be no recommendations on other vasodilators you can use, but vasodilators that you can use topically, they can go systemic. And so that's the problem. So if you use something like nitroglycerin paste, that's going to get into the bloodstream and the patient's going to get more hypotensive. So you got to be careful. I don't know of any other specific vasodilators that would be used in this kind of situation. The way phentolamine has worked is you do little injections, maybe about 20 to 50 injections around the area of tissue ischemia to try to open up the blood vessels.
Right, quite a number of questions. Looks like the topic is very interesting today. Another attendee is asking, can the parameters for the quick sequential organ failure assessment or the QSOFA scoring be translated at the community setting for early recognition of sepsis or septic shock and early coordination and conduction to the appropriate center? So is that possible, like a community setting version of a QSOFA?
So QSOFA you can use anywhere because you don't need any laboratory work for that. And there's only 3 organs that you're looking at. The full SOFA score, you do need labs. Yeah, you're gonna need a CBC and liver function panel. You're gonna need a renal panel. So yes, as far as I know, there's nothing in between the two. There's either SOFA or quick SOFA. There are many other organ failure scores that you can use, and they require various levels of laboratory work. But we have the SOFA score and the quick SOFA score, and the quick SOFA requires you to only do bedside examination and does not require any kind of laboratory work.
Okay, let's move a bit away from the pressures for the meantime, and let's go to steroids. With regards to refractory shock, Samuel Ong is asking, is there a particular parameter we look at, such as the length of time, maxing out the vasopressor dose, number of vasopressors given, etc., wherein the patient isn't responding to other resuscitation measures before we consider giving corticosteroids? So he's asking for a particular parameter to look at before we switch or we start giving corticosteroids.
So the guidance says that if you have escalating doses of vasopressors, so you're going higher and higher on your vasopressors, then you could consider adding low dose corticosteroids. The literature shows that what steroids do is help you to come off of vasopressor agents. It doesn't improve mortality. So it actually helps you to use less vasopressors. So if you're using escalating doses, or if you're dealing with refractory shock may be even too strong a word, but if you're using increased doses of norepinephrine, and that usually is probably more than 5 to 10 micrograms per minute, or equivalent of norepinephrine or noradrenaline. So you're using moderate to high dose of norepinephrine and noradrenaline. That's the general recommendation when to start or consider starting the low dose corticosteroids.
Let's go to glucose. Regarding the tight control of glucose, what is the recommended insulin to be used? Should it be rapid acting, long acting?
So if you're going to use it in a critically ill patient, you should be using regular insulin. You can use a long acting, but you're monitoring, you have to probably do a little differently. The recommendation is to keep glucose level between 150 and 180 grams per deciliter. And you can do either a slide scale or insulin drip. The recommendation is if you're going to do that, you should be using some type of protocol along with your insulin.
Right. So I'm seeing here a question on antibiotics. I just like to advise our participants, don't worry. You can ask it again in the session on antibiotics. So I will be dismissing that for now, but please ask it again when we do the antibiotic session. And what about, here we go, from YouTube, Angeli Garcia is asking, is there a role for heparinization, using heparin in these types of patients?
So yes, one of the modules that we're not going to cover is called preventing complications. And this is preventing complications in critically ill patients. And one of the complications is deep vein thrombosis or venous thromboembolism. And the recommendation is if the patient is severe or critically ill, the recommendation is if they don't have any contraindications, then you should be putting them on some type of prophylaxis for deep vein thrombosis, venous thromboembolism. And you use either a heparin or a low molecular weight heparin. And that is recommended as long as they don't have any contraindications such as active bleeding.
All right, quite a few more questions on the pressures. I'm seeing the time, 10 minutes left. Don't worry, we have a lot of time. So everyone who still wants to ask, just send in your questions via the Q&A function at the bottom of the screen for Zoom or the live chat on YouTube. So the question goes back to pressures. Can you recommend guidelines that we can turn to on determining individualized MAP, mean arterial pressure targets for previously hypertensive patients? So I think they're asking for clearer guidance.
So let me see if I understand that question correctly. Is there a specific method to determining what the MAP goal is based on certain other criteria?
Right.
As far as I know, I don't know of any. I know the guidances that I've looked at is the WHO guidance and then the Surviving Sepsis campaign. And actually the Surviving Sepsis campaign, their MAP goal is actually different than WHO at the current time. And then there's other societies that have, but as far as I know, I don't recall any specific guidance on how you would choose a specific map for specific patient.
All right. Obet Chan is asking, considering that COVID pathophysiology includes an increase in the leakiness of alveoli, causing pooling of fluids intra-alveolar pooling, can fluid resuscitation aggravate leakiness?
I think we don't know the answer to that at the present time. The guidance doesn't speak to it, but I think we're finding out a lot of things about the way COVID-19 disease acts. And these questions, is it going to act like a bacterial pneumonia that we see with something like streptococcus, or is it going to act like the way H1N1 acted about 10 years ago? And I think we really don't know yet how COVID-19 acts inside the lung and inside the vasculature. And we're learning more and more every day. The guidance does not talk about that at all yet.
All right, fair enough. So we have to wait for more information in that regard. And now another question related to the fluids. Oops, it moved a bit. Here we go. So thank you for the informative lecture. In COVID-19 patients, do you recommend combination albumin with crystalloid fluid?
Okay, so the guidance says that you can consider albumin. That's the only colloid that you could consider giving to patients in select patients, okay? It does say that the first line would be crystalloids. So you would use normal saline or Ringer's lactate or some other kind of other balanced solution. You should avoid colloids, with the exception is albumin you could consider in certain select patients.
All right. So still on the mean arterial pressure criteria. So Danas is saying, in relation to the response that one can disregard MAP criteria as long as the other HASUL parameters are met, is there a cutoff as to how many among the HASUL or HASUL parameters should be achieved? Like, is there like a 3 out of 5, 2 out of 5 before stopping resuscitation? When can you say that you're already good? Is it all or none or a few?
That's a good question. The more that you have, the better. The guidance said that, you do not have to have all of them. So if you have good mental status and good urine output, good skin signs, and the lactate's cleared, then you could aim for a lower blood pressure, okay? Or conversely, if a lot of the other markers look like they're improving, then perhaps you don't have to aim for a urine output that's more than 30 or 40 or 60 cc's an hour, okay? As far as I know, there's no specific guidance on if you have 4 out of 5 versus 3 out of 5, with not as adequate. The main goal for sepsis and for septic shock in adult patients is going to be your MAP goal. That is going to be your first main goal, and you're using them along with your other resuscitation targets.
All right.
Yeah, James, I was just going to mention, I agree with Gary on that, and that I think, at least having the MAP score, I think is going to be key. And I don't think there's any constellation of what number you need to improve, but it's really what direction you're going in is one thing. The second thing is, there's some things like mental status which might not improve if, say, there's a meningitis component or some other component. And so if you're trying to get all 5, you may not reach that in the short term. But it comes down to a clinical decision on how patients are responding, and I would guess that you'd need at least a majority, but maybe not all of those over.
All right, going back to the question on phentolamine, Hazel Dokuyanan is asking, can we use NTG, I'm assuming nitroglycerin, or terbutaline subcutaneously instead of phentolamine?
You're talking about topical nitroglycerin? If that's the question. So there's no guidance. There's no guidance on it. They mentioned phentolamine that you can use for the extravasation injury. Nitroglycerin, if it goes systemically, then there are adverse effects. There's hypotension that goes with that. So you want a medication that only acts locally, because you want to get perfusion to the skin. You don't want it to get into the bloodstream. So using something like even topical nitroglycerin, it gets into the bloodstream and it'll cause hypotension.
Right. So what about, okay, this is a bit out of scope, but I guess it can be safe to ask. Will Arthur Malikse is asking, will convalescent plasma therapy still be considered effective for patients who are already showing signs of sepsis or septic shock?
So I think some of those studies are being performed, or they're starting to perform those now. Yeah, there's nothing in the guidance that speaks to using convalescent plasma at this present time. But I know that the studies they're ramping up these studies in various countries at this time.
All right. So here's a question that just came in, but it looks very interesting and important also. In the same token, I'm assuming still on the targets for resuscitation, the HASUL. What will be your step-down action in weaning off patient from the interventions that you're giving? So from all the fluids, the inotropes. So when do you find out that you can already wean them off?
So the main target's going to be, any of those 5 targets. So you're aiming for your MAP goal primarily because it's something that you can do moment by moment. The other parameters, lactate, you may check maybe a couple times a day at the most. Urine output, you have to check hour by hour. So you can watch to see what the urine output's doing, but from doing things moment to moment, you'd have to use your mean-tail pressure. So you would titrate your pressors and come down on them primarily according to your blood pressure, your mean-tail pressure goal.
Right. The time is 11 o'clock, but there is a question in YouTube that I guess is also quite interesting. So Justin Duran is asking, in patients with sepsis and suspected COVID-19 infection, they have been found to have a sepsis-like cytokine storm syndrome. Would there be any difference in the management from other non-cytokine storm sepsis patients?
So the problem with cytokine storm is that they develop multi-organ failure. So these patients will develop respiratory failure, and they'll go into shock. They'll go into kidney failure. So if you have a patient that's developing this cytokine storm, their organs are going to start to fail. So you really need to target these resuscitation goals very aggressively to try to maintain perfusion to those organs, because they're getting affected and they're going to subsequently fail. So no, you would not do anything a lot different than with a patient that had sepsis. If you start seeing cytokine storm, then they are developing or at risk to develop organ failure. And so it'd be very important just to keep to those targets very closely, and also at the same time, not giving too much fluid. So monitoring for fluid overload. So doing your assessments. If you do get fluid, then you monitor them very closely to see if there's any adverse effects.
Right. So I'm doing my own monitoring of pressures right now. I'm just looking at the number of participants to find out if they're still interested. So there are still 133 on Zoom and 135 on YouTube, which means let's just wrap up with two last questions. Anyway, we did start just a bit late after 10. So how long do you give low dose steroids for septic shock?
Okay, so the guidance does not speak to that. There are recommendations that are in other guidances. There's no specific recommendation that I've seen. Normally, if you could consider stopping if when the patient is off vasopressor agents, you could consider doing what's called a rapid taper. So you go down day by day over about several days to off. So there's several ways that you could do it. There's no specific recommendation in the guidance regarding how you stop steroids.
All right, and this is the last technical question. The other one is more of administrative. So how does the SARS-CoV-2 virus spread to extrapulmonary organs? Do we have information on that already?
I'll input just in this last question. It's Sophie here. So my understanding from autopsies that have been performed, it actually is just in the respiratory tract and the respiratory secretions. James or Gary, do correct me if it's wrong. It has on, I think, only one occasion or very few occasions been isolated just on PCR in stool samples as well. So they're unsure as to the transmission from that side of things. So in terms of its actual spread extrapulmonarily, I don't think that is the case, but what might be referred to is if it's affecting the other organs is this sepsis and a cytokine storm that's causing reduced perfusion to other organs and causing those to shut down. Over.
All right, thanks, Sophie. So the time is 11:04. The last question is actually a commonly asked question, so we can give a response here. Thank you very much for this simple but high-yield webinar. Would you be providing certificates of completion or attendance for documentation purposes, at least for those who have pre-registered? So what we can do is, it's an entire webinar. We will discuss it with our management. If you did register, that's a good thing. We have your information on hand, and we can tell by the timestamp when you registered, because there are follow-up registrations. So for example, if you pre-registered like over the weekend, then we can safely assume that you're probably attending all of the 5 webinars. And if you registered on a particular day, then we can say that at least for that day and onwards, we will discuss it. We can't give a straightforward answer right now because it involves documentation, as you all identified. But in the same line, please do expect that we will be sending the slides over in PDF format this afternoon, along with the link to the footage on YouTube. So you can also share. You've probably already received the one from yesterday. So the one for today will be this afternoon along with the link. So thank you so much. On behalf of all the panelists of Dr. Sophie Dennis, Dr. Gary Kuniyoshi, and Dr. James Settelfinger, we look forward to having you with us again tomorrow at 10 o'clock. I don't have my quick cheat sheet, Gary. What's the topic tomorrow? Sorry.
Antimicrobials.
Antimicrobials. So there were a few questions that came out earlier, and keep those in mind. We'll welcome you again tomorrow at 10 o'clock. For those watching over YouTube, the link comes out. Pardon us, it comes out like 5 minutes before because we have to start transmitting before YouTube assigns a link. So have a good day to everyone and stay safe. See you tomorrow. Bye.